Good morning, good afternoon, and good evening, depending on where you are in the world. My name is Alejandro Calvo. I'm a medical oncologist. I work at Kettering Cancer Center in Dayton, Ohio, which is in Southwest Ohio, just north of Cincinnati. And before I start, I want to thank Dr. Jack West and the GRACE organization for all the efforts they do on behalf of our patients. I was asked to give a presentation on ROS1 rearrangement in non-small cell lung cancer. And the first slide shows a picture of the beautiful cancer center where I practice. And I want to make a comment that the treatments of lung cancer are evolving like technology, and I'm using the example of cell phones. When I was in my third year fellowship, I went to ASCO, and this was the most awaited presentation, ECOG 1594. At the time, the standard of care for lung cancer was a platinum doublet, but we didn't know which one was better. Was it paclitaxel? Was it gemcitabine? Was it docetaxel? So this was actually compared head-to-head, which is unusual in oncology, and was presented in ASCO. And just to give you a reference on the timeline, comparing with cell phones, that was a fancy cell phone. At the time, if you had that flip phone in your hand, you were rolling high. I didn't have it. Mine was a brick. So when the study results came out and they were presented, the results showed that all the platinum doublets were exactly the same. There was no significant differences. The survival was 8 months. Response rate, 19%. The time the tumor took to start growing again after a response, a little bit below 4 months. And the 1-year survival, 33%. And the reason I'm bringing this here is because if you didn't go through these times, you sometimes take for granted all the benefits we're enjoying now. So I want you to remember the response rates I'm showing you with chemotherapy and the time the tumor takes to progress again. And remember, it's below 4 months. So back then, we were in this part of the curve where we had lung cancer with 2 flavors, small cell and non-small cell. Really, if you just had non-small cell, that's all you needed to put treatment, platinum doublet. And later we started learning that the histology makes a difference. So a patient with squamous histology has different characteristics than non-squamous. And most importantly, there are some drugs that can have untoward side effects on patients with squamous cells. So we started making that differentiation. Then we moved to recognizing that there are different molecular pathology subsets, and some of them were able to be targeted. And since the cancer cells were addicted to those pathways, which is what you've been hearing throughout the morning today, that had a significant impact on the response that those patients had. And most recently, we have been using immunotherapy, and we use an imperfect biomarker called PD-L1 to make our decision in that treatment. So if you do molecular testing in your non-squamous cell lung cancers, about 50% or more are going to be found to have a mutation that can be targetable. And I think that's very, very important compared to what we were doing at the beginning of the molecular area. So in 2022, this is the complex treatment paradigm that we use regarding molecular biomarker positive advanced non-small cell lung cancer. You see here 8 potential targets. If you add HER2, which is what my colleague, Dr. Thompson, is going to talk in the next segment, you have 9 targets that you can use with different treatment options, either in first line or second line. So it's very important to identify those patients and do the test. Now, once you have the molecular testing results and there is no targetable alteration, that's when you start paying attention to the PD-L1 expression. And for the caregivers in the audience, I want to make sure that this is an important sequence that you have to remember.